Hi, good morning, everyone. This is a series of lectures on clinical ophthalmology aimed at improving the clinical acumen and diagnostics of general ophthalmologists. Eyes only see what the mind knows. In clinics, when we are seeing patients, we often forget to link the basic ophthalmology, that is, the normal structure, functioning, and pathogenesis. The focus is mainly on clinical symptoms and signs. These lectures are intended to give you an overall integrated view of the basics linked with the clinical picture, appropriate differential diagnosis, and management. In addition, I've tried to give an updated view on any advancement made in any particular disease. Please do post your queries and comments at the end of the lecture, and this will guide me to improve upon and add into these lectures. The first few, I think four or five, are on the conjunctival disease as well as on the ocular surface diseases, as these are very important and common diseases that present to us in clinics. This lecture is mainly on the conjunctival anatomy and its clinical and surgical implications, as well as a detailed anatomy of the limbal region, which is very important for every clinician as well as a surgeon. Conjunctiva forms an important part of the ocular surface, the concept of which was first given to us by Toft in 1987. Ocular surface is an integrated unit that comprises of six structures that are interconnected through a continuous epithelium, as well as having a common nervous, vascular, and hormonal control. They include the conjunctiva, the cornea, the tear film, lacrimal glands, eyelids, and the adnexa. Conjunctiva is a mucous membrane which is of integral importance to the normal functioning of an eye, as it covers and protects the underlying sclera from drying. Number two, it lines the inside of eyelids while it is folded in the fornices, thus making the excursion of eyelids over the globe smooth and independent to each other. Number three, it sustains a healthy tear film by secreting mucin that lines the corneal surface epithelium like a blanket and makes the hydrophobic epithelium hydrophilic. The fourth important function is the defense or the barrier function. The free mucin molecules are secreted by the goblet cells in the conjunctiva, and they are freely moving in the tear film, and they engulf any foreign body or bug that finds its way to the ocular surface, which are then washed away by the tear film. If these bugs cannot adhere to the ocular surface, they cannot produce disease as long as the tear film is healthy. This is explained in more detail in the recording in the lecture on corneal healing. The immune cells in the conjunctival stroma play a role in immune surveillance, and then there are the very important conjunctival lymphatics, which help in the drainage of aqueous from collecting channels to aqueous veins, thus maintaining the intraocular pressure. They support the essential metabolic functions as well as provision of cell immunity. They dilate in clinical conditions like blepharochalasis infections. The ocular surface is exposed to numerous external influences like extremes of temperature, dryness, allergens, chemicals, foreign body, bugs. So, conjunctiva protects the ocular surface from all of these. And lastly, it harbors the very important limbal stem cells, the function of which is discussed in more detail in the later slides. The conjunctiva develops from the ocular surface ectoderm and comprises of three main regions. Number one, the bulbar conjunctiva that covers the ocular surface. the palpebral that lines the eyelids, and the forniceal conjunctiva. The bulbar conjunctiva has a scleral part and a limbal part, which is demonstrated in figure A. The sclera is covered by a layer of vascularized connective tissue called the episclera, which in fact is a part of the structure of sclera. It has immune cells in it. The sclera is covered by tenon, which is a thin facial envelope containing the extraocular muscles and allowing their smooth excursion along the globe. Tenon surrounds the eyeballs and separates it from the orbital fat. A potential space, the subtenon space, exists between the capsule and the outer surface of the sclera, which is traversed by fine bands of connective tissue that link tenon to the underlying sclera. Anteriorly, the capsule fuses with the sclera 5 millimeters posterior to the corneoscleral junction, which means that tenon ends 5 millimeters posterior to the limbus. Outside the tenon lies the scleral part of bulbar conjunctiva, which is loosely adherent to the underlying tenon, and a potential space exists between the two, which is frequently used for local anesthesia. In blepharochalasis, the bulbar conjunctiva thins out and loses its attachment to tenon, resulting in conjunctival laxity, and a fold of thin conjunctiva is seen interposed between the globe and the lower lid margin, which results in tear film instability. Where the tenon ends anteriorly, the bulbar conjunctiva fuses with the episcleral tissue and then continues forwards as the most important limbal part of the conjunctiva for about 1 millimeter over the cornea. The palpebral conjunctiva lines the eyelids and is further divided into marginal, tarsal, and orbital regions, all firmly adherent to the underlying structures as shown in figure B. Conjunctival fornices are divided into superior, inferior, lateral, and medial regions. They form the junction between palpebral and bulbar conjunctivas. The forniceal conjunctiva is loose and flexible and allows for an independent movement between the globe and eyelids. It has the greatest number of goblet cells that secrete mucin, which I've already explained how important it is in the tear film, and it is mainly secreted by the conjunctival goblet cells that are mostly located in the inferior fornix, medially and near the medial canthus. Away from the fornix, the number of goblet cells reduces. Another important structure in the fornix are the accessory lacrimal glands of Cross and Wolfring, which are responsible for the basal secretion of lacrimal fluid. Therefore, the conjunctiva has the mucin secreting goblet cells as in the basal epithelium, as the glands of Mons at the limbus, and at the crypts of Henle in the tarsal conjunctiva, and then the Cross and Wolfring glands as shown in the picture. Now, coming to the histological structure of conjunctiva, the epithelium has 3 to 5 cell layers, and it is mainly non-keratinized pseudo-stratified columnar epithelium with interspersed goblet cells. The conjunctival stem cells are scattered throughout the basal layer of the epithelium, but with significantly highest levels in the medial canthal and the inferior forniceal areas. This means that the inferior fornix, especially the medial part of the fornix, is very important in conjunctival healing and providing the stem cells. The submucosa that is under the epithelium is the substantia propria that has blood vessels, fibrous tissue, lymphatic channels, melanocytes, B and T lymphocytes, Langerhans cells, and the accessory lacrimal glands. The deepest is the fibrous layer that contains the nerves and blood vessels that provide innervation and blood supply to the conjunctiva, and they dilate in various conjunctival diseases. The medial canthal and inferior forniceal area, as well as the plica semilunaris and caruncle, are densely vascularized and contain melanocytes, and they are abundantly infiltrated with both specific and non-specific immune cells. The melanocytes are responsible for making appearance of nevi and melanocytic tumors in this region. Rich vascularization provides a plentiful supply of nutrients, growth factors, and survival factors. Melanin offers protection against the carcinogenic insult from UV light and subsequent formation of reactive oxygen radicals that result in the proliferation of these melanocytes and resultant formation of nevi and carcinomas because they undergo metaplasia and carcinogenesis is more important in this region. Unfortunately, the topically administered eye medications naturally accumulate in the medial canthal and the inferior fornicel areas, resulting in toxicity from preservatives that affect mainly the goblet cells as well as the stem cells, with resultant dry eyes. Therefore, it is imperative that preservative free topical medications should be considered in any patient with significant conjunctival diseases, and especially if the medication has to be continued on a long term basis. Also, this stem cell rich zone is an area which is more severely affected in inflammatory disorders such as mucous membrane pemphigoid. The symptoms of conjunctival disease are mainly redness of the eye, which we'll discuss in a minute, discharge, which depends upon the type of affection of the or the type of the disease. That is, the discharge is watery in viral infection, allergy, or drug toxicity. It becomes mucoid with more of mucus secretion, as in VKC or filamentary keratitis, and becomes purulent in response to bacterial infection or chlamydial infection. The eyes become itchy in viral infection and allergies. Itching is not a feature of bacterial infection. And then papillae and follicle formation are the important clinical signs, which we'll discuss in a second. Follicles are mainly seen in viral infection, chronic allergy, and drug toxicity, while papillae are a non-specific sign which are present in all conjunctival diseases. As I told you that conjunctiva is richly supplied by blood vessels. These vessels dilate in response to any insult, whether it is infection, allergy, or drug toxicity. And these dilated blood vessels then become engorged and they leak profusely in response to the affecting agent. And the eye becomes red, the conjunctiva becomes boggy, edematous, chemosed. The conjunctival injection has to be differentiated from ciliary injection, which is due to the dilatation of the limbal vessels in response to corneal or uveal disease. So the conjunctival injection is maximum in the fornices and it decreases towards the limbus. There may be tiny subconjunctival hemorrhages seen in acute gonococcal infection or in florid adenoviral conjunctivitis. Dilatation is mainly of the arteries and veins in the fornices. The congested area is mobile over the sclera as a differentiating point to scleritis. These vessels are bright red and they constrict with topical isonephrine or adrenaline. An important consequence of dilatation of these blood vessels is the formation of membranes or pseudomembranes. Fibrin and protein rich fluid transudates through the walls of dilated, damaged blood vessels. It accumulates over the tarsal conjunctiva and finally coagulates in exuberant gonococcal or adenoviral infections. And it forms a whitish pseudomembrane that can be easily peeled off the inflamed underlying tarsal epithelium. On the other hand, the true membrane is firmly adherent to the underlying epithelium because of the severe infection, especially gonococcal or diphtherial, and any attempt at removing the true membrane will result in peeling off the superficial epithelium of the conjunctiva and severe bleeding as well because of leaving behind the raw area of the epithelium and exposing the substantia propria. Papillae are the Papillae form in any conjunctival disease. The swollen tarsal conjunctival epithelium appears red, gelatinous, or velvety. A papilla is normally 1 to 2 millimeters with a central feeding capillary surrounded by inflammatory cells and an overlying edematous epithelium. With prolonged inflammation, the fibrous septa, which anchor papilla to the underlying submucosa, rupture. Adjacent papillae coalesce to form giant papillae, as seen in VKC or in response to foreign body like contact lens wearers, prosthesis, or in response to corneal sutures. Follicles are seen mainly in the tarsal conjunctiva, and they are formed in response to follicles are pale, shiny, tiny aggregates of lymphocytes. As I told you, B and T lymphocytes are present in the substantia propria as well as in the fibrous layer of the conjunctiva, and they proliferate in response to viral or chlamydial infection or drug toxicity. An accompanying marked papillary response to a florid viral infection may hide the underlying follicle formation. Therefore, looking at the clinical signs, it's easy to differentiate between viral, bacterial, and infections as well as the drug toxicity. Now, coming to the anatomy of the limbus, which is an extremely important structure, and its significance is fourfold as it is an important surgical landmark for every surgeon. It harbors the most important limbal stem cells that are crucial for corneal healing. Internally, the limbus is a site of the angle of the eye, which has important structures like iris root and the ciliary body. And number four, it forms the important pathway for the drainage of aqueous. The limbal area is not a straight line but an oblique transitional zone because, as shown in the figure A as well as B, the conjunctiva continues for about 1 millimeter over the corneal surface. Number two, the Bowman's membrane of the cornea ends early, while the Decime's membrane continues backwards for about 1 millimeter before ending at the Schwalbe's line. Therefore, this makes the limbal area oblique, as shown in the diagram A and B, and this transitional zone is only visible to the surgeon once the conjunctiva is reflected and it appears as a bluish gray area. Therefore, the anatomical limbus that we see on the slit lamp is quite different from the surgical limbus. The anatomical limbus comprises of number one, the corneoscleral junction, where the transparent cornea with its regularly arranged corneal stromal lamellae merge with the white sclera with its irregularly arranged collagen lamellae. And then second part of the limbus is the corneo-conjunctival junction, in which I've mentioned that the tenon fuses with sclera 5 millimeters posterior to the corneoscleral junction, while the conjunctiva continues forwards onto the cornea for a variable distance in each quadrant of the globe. It continues for exactly 1.2 millimeters in the superior part of the limbus, 0.8 millimeter inferiorly, and 0.4 millimeter nasally and temporally. Therefore, the conjunctivo-corneal junction lies 1.2 millimeters anterior to the corneoscleral junction in the upper part of the limbus. Here, the bulbar conjunctiva is densely adherent to the underlying episcleral tissue. Figure B shows the histological section of limbus in more detail, where episclera is shown to end at the oblique limbus, while conjunctiva continues forwards as multi-layered, stratified columnar epithelium called the palisade of Vogt for a distance of 1.2 millimeter at the superior limbus, as shown in figure C. After that, it becomes continuous as the stratified squamous epithelium of the cornea. The lamina propria of the conjunctiva ends at the limbus, where it is continuous with the Bowman's membrane, while the scleral lamellae, irregularly arranged, become continuous with the corneal stromal lamellae, which are regularly arranged. The decimus membrane terminates at the Schwalbe's line. Corneal endothelium becomes continuous at the limbus with the epithelial lining of the trabecular meshwork. So also note in figure B that the external limbal area between conjunctiva and cornea possesses the most important multipotent limbal stem cells, while the internal limbal border zone between corneal endothelium on one side of the limbus and sclera on the other side contains the specialized cells of the trabecular meshwork. So this limbal zone has on the outer side the important limbal stem cells, while on the inner side internally has the important trabecular meshwork. The limbal stem cells present as a unique structure of the palisade of Vogt are critical in forming a barrier between the avascular cornea and the vascular conjunctiva. As long as they are healthy, corneal vascularization cannot occur. They are also extremely crucial for corneal regeneration and wound healing. These functions are pivotal in maintaining corneal transparency. In addition, the limbal epithelium contains the lymphocytes as well as vascular and lymphatic vessels that serve to provide nutrients and cytokines to the surrounding structures, as well as making the peripheral cornea more susceptible to immune mediated inflammation, as seen in VKC, marginal keratitis, or flictanular conjunctivitis. In these conditions, chronic limbal inflammation or limbitis results in loss of stem cells with peripheral corneal edema and ingress of vessels into the edematous stroma with pannus formation. So, limbal stem cells also provide a barrier to conjunctival epithelial cells, thus preventing them from migrating onto the surface of cornea, and conjunctivalization of peripheral cornea with the presence of opaque goblet cells and an unstable epithelium occurs in these conditions. The healthy stem cells require an adequate supply of growth factors from the tear film, as well as control of limbal inflammation or continued mechanical damage from contact lenses. And this diagram represents the role of limbal stem cells in corneal healing, which is discussed in great detail in the lecture on corneal healing. So please go through that. Now, coming to the surgical limbus, which is a 2 millimeter wide circumcorneal transitional zone viewed externally by the surgeon once the limbal conjunctiva is reflected. So it is bounded by the anterior limbal border, which is the junction between the clear cornea and the limbus, marked by a prominent ridge created by the insertion of conjunctiva into the cornea, and the Bowman's membrane ends here. It corresponds to the most anterior limit to which the conjunctiva can be reflected, as shown in figure B. This is followed by the blue limbal zone, which is a variable zone in different quadrants due to the variable insertion of conjunctiva into cornea, as I've already explained. It extends 1.2 millimeter posteriorly, especially in the superior limbus, where the Decime's membrane ends and is marked by the Schwalbe's line, which is in fact the ending of the Decime's membrane. And this is the most useful external surgical landmark. Then the posterior limbal border is visible as a sharp line of demarcation between the bluish limbal stroma and the white sclera. It is overlying the scleral spur, and this forms the posterior boundary of the surgical limbus. Therefore, remembering these surgical landmarks is very important, in which the anterior limbal border represents the termination of Bowman's membrane and is actually the anterior extent of conjunctiva. Then the blue limbal zone is bordered by the Schwalbe's line, and this is the termination of the Decime's membrane. The white zone overlies the trabecular meshwork, and this is bordered posteriorly by the posterior limbal border, which is actually the marking of the scleral spur. So you can see clearly the surgeon's view as shown in the figure, where the clear cornea is seen, and then the limbal area for about 2 millimeters extend in which the gray zone is clearly visible, and then posteriorly by the sclera is seen. So these are important. These surgical landmark is important as they bear the important incision sites or entry into the anterior chamber. A clear corneal incision will lie in front of the anterior limbal border, and this is associated with high astigmatism and stripping of the Decime's membrane, as well as wound entering the anterior chamber through the Decime's membrane and endothelium. An incision in through the blue limbal zone will traverse through the Decime's membrane and may lead to its stripping. On the other hand, a mid-limbal incision, which is located at the gray limbal zone in front of the Schwalbe's line, and this is the most preferred site of entry into the anterior chamber. Then number 4 is a posterior limbal incision, which is located at the white limbal zone, and this may damage the underlying trabecular meshwork. And number 5 is a scleral incision, which is located posterior to the posterior limbal border. It cuts the sclera behind the scleral spur and enters the supraciliary space overlying the iris root. Therefore, it will damage the iris root and will result in extensive bleeding and hyphema. So a thorough knowledge of this surgical limbus is extremely important for a corneal surgeon as well as for a cataract and glaucoma surgeon. So I hope this lecture was useful in highlighting the fact that conjunctiva is an extremely important part of the ocular surface. Since it performs so many useful functions, it must be handled carefully during surgery as well as in conjunctival diseases, which are so common. A minimal number of topical medications must be prescribed for a minimal time period to avoid drug toxicity, And since the limbal area with the ever important limbal stem cells are crucial in maintaining corneal transparency and clarity, this limbal area must be handled with great care. A thorough knowledge of the anatomy of the limbal area is a must for every surgeon. Thank you very much. If you have any queries or comments, you can leave at the end of the lecture. Thank you so much.